Hi everyone, very good evening and welcome to Images Decoded. Well, this is a series which was conducted last year and here we are with an updated version of the same. We've conducted a couple of lessons of general path and then following that we are currently on systemic path. This series is conducted on a daily basis, that is Monday to Friday, on the Unacademy YouTube channel, and this is uploaded every day at 9 p.m. So, well, before I begin, I'll just give you a brief of what all is planned for this entire week. Like today morning, we had a session on lengthy questions. Then in the afternoon, we had the FMG crash course. And now we are going to begin with renal pathology images part 1. Similarly, these trio classes will be continued almost on a daily basis, Monday to Friday, as I said. And there'll be a class in the morning at 7:30 that will be on the app. Then 3 p.m. again on the app and 9 p.m. on the YouTube channel. So for today and tomorrow, we are going to cover a chapter that is renal pathology, kidney path images. So we undoubtedly know that this is something extremely important. And also one more thing, all these classes are free classes. So each one of you is most welcome to come and attend all of these. In case you wish to take the plus subscription, then these are the different subscription plans that are available on the platform. Well guys, starting with renal path, starting with kidney, before we begin with the diseases, it's important for us to understand the normal of the kidney. Now that's where we probably falter the most. If we understand the normal of the kidney, half of our life becomes, the problem definitely is sorted to a great extent. So when I talk about kidney, I know what I see in this image over here is a glomerulus, and I can see that there is an afferent arteriole that is taking the blood to the glomerulus. Then there are a tuft of capillaries that are formed inside, and then the blood is coming out via the efferent arteriole. So afferent enters and efferent exits. Okay, this is the blood supply. What about the Bowman's capsule? So when I'm talking about the Bowman's capsule, I have a layer which continues. So I have an outer layer of the Bowman's capsule, the blue color one, known as parietal epithelial layer, and that is continuing on the inside also, and this inside one is known as the visceral epithelial layer. So this is the Bowman's capsule epithelium, the parietal being the outer and visceral being the inner. So what's the space between the two? Between the parietal and the visceral, this space is referred to as the Bowman's space. That's the name given to it. Having said that, now we also have that, for example, if this is one capillary loop, this is one capillary loop, this is another capillary loop. So there are some cells which are present in between as well, in between the capillaries, in the middle. And the cells in the middle are the mesangial cells, the mesangial matrix. M for M. So remember, the cells which are present in between or in the middle of the capillary loops is the mesangial matrix, and those are nothing but macrophages. So repeating for all of you, first we have a blood vessel pole. What is the blood vessel pole? The vascular pole. So the afferent enters, efferent exits. Then we have a urinary pole through which all the urine formation is going to happen and is going to proceed to the different PCT, DCT and so on. So that comprises number 1 of Bowman's capsule, outer parietal, inner visceral. Having said that, where exactly does the urine formation occur? If I have to pinpoint that area out here, it is at the junction of the blue and the pink. So what is the blue layer? The blue layer is the visceral layer. And what is the reddish pink thing? That is the capillaries. So what is this known as? This is known as the filtration membrane. Repeating for all of you, a filtration membrane, if I can ask you the theory first and foremost, what all does a filtration membrane have? So remember, a filtration membrane is not a one layer thing. A filtration membrane is a 3-layer phenomena that you have to know. It has 3 layers. What are the 3 layers? Let us, so indirectly can I also say it is trilaminar. It is going to have 3 parts to it. Yes. So the first one, and see if you remember, one has to be the capillary part, one has to be the blue color visceral part. So the capillary part, what is the lining of the capillary? The lining of the capillary are the endothelial cells. That's number 1. What was the blue color one? The blue color one was the visceral cells, right? So on the outside, I will write visceral epithelial cells of the Bowman capsule, and they have these foot processes. These cells are not just plain simple cells. They have these foot processes, or foot processes are also known as podocytes. Sandwiched in between the two. So on one side I have the endothelium of the capillary, on one side I have the podocytes and the epithelial cells, and sandwiched in between the two is the glomerular basement membrane. So that is what I asked you. What are the three layers? So number one, you will say there is a capillary endothelial cell layer. On the inner side it is endothelial cell that is present. On the outside there is a visceral epithelial layer that is present, and not the entire cell that I'm more or less worried about. I am more concerned about the food processes of that cell. And finally, sandwiched between the two, we have the glomerular basement membrane. So now if we look at them one by one, if I look at them one by one, so for example, if this is the diagram that I have, look at the capillary endothelial cells. Are they like totally joined to each other, or are they having gaps in between? I see a few gaps. So this is known as the fenestrated endothelial cells. These gaps are known as, they are approximately 70 nanometers and above. They are fenestrated endothelial cells, so that material can pass out. This side has the blood, right? This is all the blood and all the waste products. You want all of it to go out into the urine. So it has to have some gaps, right? That's the fenestrated endothelial cells. Then what do I have next? The next one, that is on the outer aspect. On the outer aspect, you have these podocytes. This is how, I'm just going to zoom into one of the podocytes. Podocyte further has many different proteins. So if this is a podocyte, on the projecting from the outside, or projecting outside the cell, is something known as nephrin. Nephrin is something that is projecting outside. Then protruding inside is podocin. So nephrin is outside, podocin is inside. So this is becoming obviously podocin. That is attached to a molecule called CD2 associated protein, CD2AP, and that is attached to a molecule called actin. So repeat, on the outside projecting there's nephrin, then inner side there is podocin attached to CD2 associated protein and thereby attached to actin. So that makes one entire visceral epithelial cell. So I've done the meaning of the capillary endothelial cell. I've done the meaning and the details of the visceral epithelial cells. What am I left with? I'm left with this glomerular basement membrane. Now let me tell you guys, if you see very carefully, I have drawn the basement membrane in a manner that one part is a different color and the other part is different color, because the glomerular basement membrane further has three parts. What are the three parts? So see, listen carefully. In the center of the basement membrane is very, very dense. So I call it lamina densa. Because it looks very dense, I call it lamina densa. Obviously, the peripheries are not so dense. So this can be known as lamina rara. This part is not very dense, so I call it lamina rara. Similarly, this part is also not very dense, so I call it lamina rara. But then what's the difference? See, this one is on the inner aspect, so I call it lamina rara interna. And that one is on the outer aspect, so I call it lamina rara externa. That is how I differentiate between the two raras. Otherwise, if I repeat, the centermost part is known as lamina densa, the outer one lamina rara externa, and the inner one lamina rara interna. That is a glomerular basement membrane. So now whatever we've studied up till now, let us put it up and fit it in a picture over here. Let us enlarge. So first and foremost, it's a black and white picture, means I'm dealing with electron microscopy. Thereafter, over here I see this cell gap, cell gap, cell gap, cell gap. So what layer does this become? This becomes the fenestrated one. This means this is the endothelial cell layer. This is the fenestrated capillary endothelial cell. On the outer aspect, what do I see? I can very well visualize over here the podocytes. I can see the podocytes. So this becomes the podocytes or the visceral epithelial cells. Coming to what is sandwiched in between, I think everyone can appreciate. Sandwiched in between, we have something known as the glomerular basement membrane. Done with this, this is all about the normal filtration membrane. And now things become a lot easier. So this is electron microscope. How about looking at a light microscope of the kidney? So what do we have over here? This really round structure out here. This round structure is referred to as a glomerulus. And obviously the glomerulus will be lined by this outer capsule. You know it is a Bowman's capsule. And all these red blood cells that you're seeing inside, these red blood cells means that we have capillaries out here. So the red blood cells indicate capillaries, and then what are those different cells otherwise? Those blue color dot cells in between, middle mein. What is in the middle? In the middle we have mesangium. Okay, having said that, apart from that, I also see there are some big tubules like proximal convoluted tubules. There are certain smaller tubules like distal convoluted tubule. We'll gradually study about it. But if I say that in this entire thing, you want that you should highlight the basement membrane and you should highlight, with different stains, then what are the two stains that I use for basement membrane? So there's a pink color stain that you see over here. There's a little blackish color stain that you see here. So if you see the Bowman's capsule, it becomes very pink. And if you see all the capillaries, they've also become very pink. So pink stain is PAS. PAS positivity for basement membrane. PAS gives a pink color. But when I'm talking about the black color stain, this is, see, the entire Bowman's capsule has become black. The capillary basement membranes have become black. That is GMS. What is GMS? It is Gomori methenamine silver stain. Gomori methenamine silver stain is what is the black color stain. Anyway, I think I know this concept by now, that whenever I have a silver color that is given to me, the color that I'm eventually going to get is going to be a black color. That's the concept that I have. So when I'm talking about PAS, I'm talking about pink color. When I'm talking about silver, I'm talking about black color. Well, with that, all your normal basics are done. And before I now move on, now we go on to nephrotics and nephritics, because we are talking about the normal kidney. Let's see some variations. Let's talk about some variations that can happen, or you can say the different gross appearances of the kidney. And what will I begin with? I'll begin with the NEET PG 2021 question that came. So this was the exact image that came, the radiological image came. There was a patient who was suffering from sterile pyuria. So the urine was showing us sterile pyuria, means that there was pyuria, that is pus cells. Pus cells were present in the urine, but there were no bacteria seen in the urine. Sterile pyuria. It did not show growth on, the bacteria were not showing a growth on the culture media. That is something that you see in case of TB. And what does TB lead to in the kidney? It leads to putty kidney. So this is the gross of a putty kidney, and you can see these areas of what necrosis do you expect in TB? Everyone knows that we expect the caseous necrosis, and caseous necrosis can also be associated with calcification. So yes, all this is caseous necrosis and calcification, and you call it putty kidney. Putty refers to cement, so it has a cement-like appearance. Next, the same thing can be visualized over here on radiological examination. This is the necrosed and the calcified area. This is the putty kidney. Repeating, putty kidney, the patient in the urine will show you sterile pyuria, disease, tuberculosis. Next we have is that the kidney has started becoming grainy, granular. So if you look at the kidney out here, if I highlight the kidney out here, it's not, very smooth and shiny. It's a little granular. I can see granularity, fine granularity, leather grain appearance of the kidney that you see in a case of benign hypertension. So if you see leather grain kidney in a case of benign hypertension, what do you see in a case of malignant hypertension? So in a case of malignant hypertension, we see the presence of flea-bitten kidney. So what do you understand by flea-bitten kidney out here? All of you can very well visualize that there is a kidney and you have some dark red color spots on top of it. These dark red color spots are nothing but punctate hemorrhages. So what do you see in a case of malignant hypertension? In malignant hypertension, we see punctate hemorrhages. It looks like a very dark spotted kidney, so you call it flea-bitten kidney. Now, something similar I've already taught you in the images decoded of blood vessels, because there also I was asking you that, okay, fine. Now you've read that in benign hypertension, in the kidney, I see the leather grain appearance. But what do you see in the blood vessels? Similarly, in malignant hypertension, in the kidney, I see flea-bitten kidney. But what do I see in the blood vessels? So, can we recall? I hope you remember that when we are dealing with a case of benign hypertension, benign hypertension in the kidney, what will it show you? It will show you leather grain appearance. The same benign hypertension in the blood vessels will show me hyaline arteriolosclerosis. What is hyaline? Lot of pink material. So can you see this blood vessel? And can you see this is a tiny lumen out here? Same way, this is a blood vessel and this is a lumen out here, and very well we can appreciate this pink color getting deposited. Hyaline arteriolosclerosis for benign hypertension. Similarly, when I'm dealing with malignant hypertension, what does the kidney show us? Flea-bitten kidney. But what does the blood vessel show us? In a case of malignant hypertension, the blood vessel shows us hyperplastic arteriolosclerosis, hyperplasia of smooth muscle. So remember, it shows us the classical onion skinning pattern. The blood vessel will show you onion skinning pattern. So let us take the example of a kidney only. Imagine that you got this kidney, it was showing you a lot of this hemorrhages and flea-bitten appearance. You took a little bit of tissue and you're seeing it under the microscope. So this happens to be the glomerulus, this glomerulus. And this is the blood vessel supplying the kidney. So let me zoom into this blood vessel out here. If you see, it shows you a round and round kind of a pattern. It shows you onion skinning. Means it's showing me hyperplastic arteriolosclerosis. So benign hypertension, hyaline arteriolosclerosis, malignant hypertension, hyperplastic arteriolosclerosis. The next one is when the kidney starts looking waxy, and that is seen in amyloidosis. Now let me tell you guys that whenever the word waxy means it's candle wax like. So you can very well appreciate both the kidneys showing you a similar appearance. Now, whenever the word waxy comes, they are trying to tell you about amyloidosis only. That's like the most famous word that you use for amyloid description. The organ becomes waxy. So, if they're asking you waxy kidney, waxy liver, waxy spleen, they're always talking about amyloidosis. Well, let me tell you further that is there any gross stain? You say that fine, I'm seeing a very waxy kind of an appearance over here. Can I add something which will let me know that okay, is it amyloid or not? So the gross stain that we have is Lugol's iodine. And on adding Lugol's iodine, what color am I expected to get? We expect a mahogany brown color. And if we get a mahogany brown color, so what do? I take a dropper, I take few drops of Lugol's iodine and I put Lugol's iodine over here. What color will I get? If this has a myeloid, I'll get a mahogany brown color. To that, I'm going to add H2SO4, sulfuric acid, and then it will turn blue in color. This will confirm or at least tell me that yes, amyloid is present. So repeating, the question that you get is what is the gross stain? The main stain is Lugol's iodine and you get a mahogany brown color. On top of that same color, if you add H2SO4, it will turn blue, and that is a property of amyloid. Obviously, one more question which you studied in amyloidosis is that when you are talking about amyloidosis of the kidney, what happens to the size of the kidney? That's another very important question that they ask you in the paper. So, whenever amyloid sits in any organ, be it the tongue or the heart or the liver or the spleen, the size of the organ increases. There is always a case of organomegaly. And that will happen with kidney also, but only in the initial phases. Initially, the kidney will increase in size. Initially, organomegaly happens. So, this implies that the kidneys are going to increase in size. However, later cases, what happens in later cases? Not with all organs. In later cases, the kidney tends to shrink. And why is that so? So, I'll draw a diagram and try and explain it to you. So what happens if this is a glomerulus, guys? And all of you know these are the different capillary loops that we have, right? The different capillary loops that are there. So where is amyloid getting deposited? Amyloid tends to get deposited more in the mesangial region. Amyloid will get deposited in the first place where amyloid gets deposited. That's a question. The first place where amyloid gets deposited in the kidney is referred to as the mesangium. So imagine this amyloid, I've made it as yellow color. This amyloid is getting deposited in between. Imagine it's going on and on getting deposited. Will it start compressing on the blood vessels? Yes. So can I say there will be ischemia that the kidney will suffer from because the amyloid is compromising the blood supply? And if there is ischemia, will it lead to shrinkage of the kidney? Exactly. So that's the question that you get in the exam. All the other organs show you only organomegaly. Kidney also shows you organomegaly, undoubtedly. Kidney also shows you organomegaly, but in the later stages, later is the word you have to remember, the kidney shrinks in size. Coming to the next gross appearance, we have a case of CPN. What is CPN? It is chronic pyelonephritis. Chronic pyelonephritis. So what do you have to know in chronic pyelonephritis? Here you have a kidney, you have the ureter moving out, and you can see these cortical scars. You can see the cortical scars. Please remember, these can be seen very commonly. They are located at the poles. Usually they can be seen anywhere, but they are more commonly located at the upper and the lower poles. And this is an asymmetric contracted kidney. Let me tell you, this contraction is asymmetric contracted kidney. So they ask you, what is the differential diagnosis of a contracted kidney? So you say, if you're talking about asymmetric contracted kidney, it is CPN, chronic pyelonephritis. Whereas if you're talking about symmetric, that is seen with chronic, not chronic glomerulonephritis and benign hypertension, benign nephrosclerosis or benign hypertension. So these two, please remember, if you're in second year, this becomes a very favorite viva question. Symmetric contraction is seen in CGN and benign hypertension. Asymmetric contraction is seen in chronic pyelonephritis, the one that I had shown you here. So why not see the microscopic examination of a case of chronic pyelonephritis? So when I'm seeing chronic pyelonephritis microscopic examination, this is what I visualize. Well, out here we see that there are, first and foremost I need to analyze the word. If I'm saying chronic, you will say yes, this is a long term thing. If I say itis, you will say it is an inflammatory disorder. So it's a chronic inflammation. What is the cell of chronic inflammation? Lymphocytes, macrophages. So what are the cells that I'll see over here? I'll see lymphocytes because it's a chronic inflammation. Inflammation of what? Is it glomerulonephritis or pyelonephritis? It's pyelonephritis. So will the glomerulus be affected or will the tubules be affected? So the common sense tells me that the tubules will be affected. So first and foremost, if you look everywhere, there are these tiny blue color dot kind of cells. Very, very important. So I'll enlarge for you these tiny blue color dot kind of cells. These are all the lymphocytes. That is what you said. They show you lymphocytic infiltration because it's a chronic infection. Next, you said it is a tubular problem. So the glomerulus will be affected? No, the glomerulus is not affected. The tubules are affected. So how are they affected? Let's draw it out. There are two things that you'll see in a tubule. Normally, a tubule has some kind of a cuboidal epithelium. Tubule has some kind of an epithelium, but in this case, what happens? There is no epithelium. See, normally epithelium is there. In this case, there is no epithelium, so I can say atrophic lining. Number two, this is filled with pink material. The atrophic tubule is filled with pink material known as thyroidization of the tubules. Very famous question in the exam. Thyroidization of the tubules is seen in chronic pyelonephritis. So let's find out the thing that we've read? Look at the tubules, guys. Lots of tubules which are filled with pink color material. Yes, so that's thyroidization. Means it started to look like the thyroid. Like in the thyroid, this would be referred to as colloid, right? So similar to colloid. It's not thyroid gland. It's just a similarity that they've made. That because it starts looking like the thyroid, so I call it thyroidization of the tubules. So these were the two main findings that you get. Means it is a case of CPN. So CPN is actually all about lymphocytes, chronic inflammation, which we've seen, tubular findings, which we've seen. But there's one thing that you have to know. I've told you that it is a tubular disorder, pyelonephritis, tubular disorder. It has nothing to do with the glomerulus. However, if they ask you which is the only glomerular finding that you can get in a case of chronic pyelonephritis, you will say the only glomerular finding is not in the glomerulus but around the glomerulus. Periglomerular fibrosis. So, for example, if this is a glomerulus and these are all the capillaries inside it, you will see a lot of fibrosis that is happening around it. So let us see over here. Look at this one, almost gone. Pink fibrosis over here. All these round structures are totally engulfed with fibrosis. So the only glomerular finding that you see in pyelonephritis is periglomerular fibrosis. Having said that, done with the findings of CPN, it will show you cortical scars, it will show you lymphocytes, the tubules will show you two things. Number one, the lining will become atrophic. Number two, there's going to be something known as thyroidization. And when you're talking about the glomerulus, the only glomerular finding is periglomerular fibrosis. Now, since we're talking about the gross appearances, how about another one? No points for guessing that this is a case of PKD, polycystic kidney disease, because I can see abundance of cysts. But I've got two views over here. One is an outer surface, one is a cut surface. Is the outer surface showing you cysts? Yes. Multiple fluid-filled cysts are seen. Is the cut surface, inner surface showing you cysts? Yes. So when both surfaces, that is both outer and inner surfaces, show you the presence of cysts, that is known as the autosomal dominant variety. Autosomal dominant PKD. How did we learn it? Autosomal dominant. How do you write dominant? If you see the word dominant, then it sounds like dono. Dominant means dono. Outer surface will also show you cyst. Inner surface will also show you cyst. Dono surfaces will show you the cyst. It is autosomal dominant. However, if they put up a scenario in which they say that the outer surface is normal, if this is what they say, the outer surface is totally looking normal. However, there are cysts which are hiding inside, receding inside. Cysts are on the cut surface only. That is when you say that I'll suspect autosomal recessive. So only the cut surface is showing you cysts. You say that I will expect autosomal recessive variety. So how have I learnt it? In recessive variety, you are seeing they're receding inside, they're hiding inside. Outer is normal. In autosomal dominant, you can very well see that they are present all over, outside also, inside also. So that is dono varieties are seen. Well, having said that, gross appearances are almost done with one last gross appearance that is actually to do with the urinary bladder. So when I talk about the urinary bladder, I can see over here this is a bladder, and I can also see over here that these are the two tiny ureter endings which are happening. And what is in the bladder? In the bladder I see these yellowish mucosal plaques. Yellowish mucosal plaques. So they might sometimes be mistaken for malignancy. Is this a malignancy? No. What disease is it? This disease is known as malacoplakia. This disease is malacoplakia, and this is a defect in phagocytosis. It's a phagocytosis defect. Well, having said that, now I see that grossly it is showing me yellowish plaques. Clinician might have mistaken it for malignancy. I need to pick it up microscopically. So first let me tell you the theory which is going to help you, and then I'll show you the image out here. So what do I see in a case of malacoplakia? So M for M. Malakoplakia shows me the presence of MG bodies, Michaelis-Guttman bodies. So obviously you'll want to know what are Michaelis-Guttman bodies. Michaelis-Guttman bodies are made up of calcium. So there is going to be a cell like this. There's going to be a cell, then there's going to be a nucleus of that cell. But apart from that nucleus, you will also see some bluish color material that is lying inside it. And what is this bluish color material? This bluish color material is calcium. This means which bodies are these? These are the Mg bodies. On the other hand, what was this entire cell which has eaten it up? Which is the foodie cell which eats up everything? The foodie cell is always the macrophage. So what is this macrophage known as? This is known as the von Hansmann cell, and that is the scientist after which it is named. So what is a von Hansmann cell? It's a macrophage which has eaten up which bodies? It is a macrophage which has eaten up the Michaelis-Guttman bodies. So please remember, ultimately M for Malakoplakia, M for a macrophage known as von Hansmann cell which has eaten up M for Mg bodies made up of calcium. Let me now show you the same thing with the help of an image, and I'll zoom into the image so that we can see it in detail. So over here, if you look carefully, I'll try to highlight one cell which will tell you the entire story and pick up this one. Can you see that this cell is a macrophage? This happens to be the nucleus of the cell, and this blue color material happens to be calcium. So which bodies will you call this calcium? I'll call them the Mg bodies. And what is this entire cell known as? This is known as the von Hansmann cell. Okay, so with that, I'll just give you a quick recap of all the gross images. Number one, the one that was looking like cement and the one that you had with caseous necrosis was putty kidney, seen in tuberculosis, same seen radiologically. Patient will present with sterile pyuria. In benign hypertension, what do we see? We see the very famous leather grain kidney, granular surface. In malignant hypertension, we see the very famous flea-bitten kidney, again a very important question. Then when we go for amyloidosis, we see the very famous waxy kidney. Then when we go on to chronic pyelonephritis, we see asymmetric scarring, and microscopically the most famous finding is thyroidization of the tubules. Then when we are talking about polycystic kidney disease, outer and inner surface showing is autosomal dominant. Only the inner surface showing me cysts becomes autosomal recessive. Moving from the kidney, going into the urinary bladder, when you see yellowish plaques, it is a case of malakoplakia, can be mistaken for malignancy. It shows you the presence of M for Michaelis-Guttman bodies. These are made up of calcium. They are eaten up by macrophage, and macrophage is known as the von Hansmann cell. So well, honestly speaking guys, I thought that we are done with our 30-minute session for the day. I had thought that we'll keep this in 2 parts, but now I feel that we'll have to extend renal path into 3 parts because the number of images are definitely more, but nothing to worry about because we'll go in the same order. We'll add another session and then we'll start later on with the mixed bag. So tomorrow at 9 o'clock, I'm going to continue with renal path, that is part 2, and in that I'm going to again go in for certain important urine findings like casts and crystals and then maybe tumors. So yes, that is what we'll be uploading tomorrow, and then we'll have another session on the nephrotics and the nephritics that you have to know. Well, thank you so much for joining in today, and I hope you guys are also following the Kickstart morning and the afternoon post lunch sessions on the app. So thank you so much. See you tomorrow same time at 9 o'clock. Good night.